Thank you for Professor Merkley for the nice introduction. In the present talk, I'm going to discuss an innovative technique that is based on a new heart rate variability algorithm that can be used for the non-invasive detection of myocardial ischemia and coronary artery disease. Currently, the non-invasive detection of myocardial ischemia requires complex imaging modalities that are frequently associated with relatively low sensitivity and specificity, such as in the case of exercise stress testing, possible radiation exposure, such as in the cases of myocardial perfusion imaging and CT coronary angiography, and relatively high cost, such as in the cases of most frequently used and commonly used modalities for the diagnosis of myocardial ischemia and coronary artery disease. In contrast, heart rate variability is a non-invasive and relatively inexpensive test that does not require the patient to be exposed to ionizing radiation. In addition, the test does not require the patient to exercise if he's not able to, such as in the case of conventional exercise stress testing. Heart rate variability, especially attenuated heart rate variability, has been shown in prior studies to be highly correlated with an increased risk for all-cause mortality, cardiovascular death, and sudden cardiac death. Furthermore, recent data suggest that heart rate variability is attenuated in patients who have coronary artery disease and therefore may be possibly used for the early detection of myocardial ischemia. Based on this data, a novel heart rate variability, the heart trends, was developed by Level for the purpose of non-invasive detection of myocardial ischemia using simple 1-hour Holter testing. As can be seen in this slide, the device is relatively easy to use. As a first stage, the baseline clinical data of the patient are being recorded on a disk. Subsequently, this disk is being transferred into a simple Holter device, which is placed on a patient for 1 hour without the patient having to exercise, just simply rest. After this 1 hour, the data from the Holter is being transferred electronically to the Level Coordination Center, where it is being analyzed using the heart rate algorithm. And within 5 to 10 minutes, these results are being transferred back to the physician's clinic with a simple dichotomized answer as either positive with a DY/Dx indicator value that is below 2, which is highly suggestive of increased risk for myocardial ischemia, or DY/Dx indicator value that is above 2, equal to above 2, that essentially rules out the presence of significant myocardial ischemia. Based on a pilot study that we carried out in 100 patients, we hypothesized that the heart rate algorithm is superior to conventional exercise stress testing for the detection of myocardial ischemia. And accordingly, we carried out a prospective multi-center study that was designed to validate the diagnostic performance of the heart rate test for the detection of myocardial ischemia in patients who do not have previously diagnosed coronary artery disease. As I mentioned, the study was a prospective multi-center clinical trial that enrolled 450 patients. The inclusion criteria were age that was equal to or greater than 21 years, referral for exercise myocardial perfusion imaging by the treating physician, and we were able to provide written informed consent. The design of the study was as follows. First of all patients underwent digital 1-hour Holter testing, which was followed by exercise stress testing together with SPECT myocardial perfusion imaging. After the two tests, the results were analyzed, the Holter data was analyzed using the heart rate algorithm. And finally, the results of the two tests were compared between the conventional exercise stress testing and the heart rate variability results for the detection of myocardial ischemia using the gold standard of a positive myocardial perfusion imaging test. The definition of the test was as follows. A positive conventional exercise stress test was defined according to current ESC, AHA, and ACC guidelines, as can be seen in this slide. A positive heart rate result was designed and based on the Holter output, which was translated into a score called the dy/dx indicator value. And as I mentioned earlier, a dy/dx indicator value, which is below 2, is considered to be positive and is highly suggestive of the presence of myocardial ischemia, as will be seen later. In contrast, a result which is equal to or greater than 2 can essentially rule out the presence of significant myocardial ischemia. And finally, a positive myocardial perfusion imaging test was designed and based on the presence of greater than 5% reversible myocardial ischemia, as noticed and diagnosed by Getty-SPECT MPA. The parameters that were assessed in the present study included the sensitivity, specificity, positive and negative predictive values, with a comparative analysis that was used between the heart trend test and conventional exercise stress testing for the endpoint of myocardial ischemia as diagnosed by a positive myocardial perfusion imaging test. When we look at the baseline clinical characteristics of the patients that were enrolled, we see that the mean age was 61, 43% were at an age that was equal to or greater than 65 years, 62% were males, with a relatively high frequency of baseline clinical risk factors, including hypertension, dyslipidemia, diabetes mellitus, and a family history of coronary artery disease. Furthermore, more than 40% of the patients were either past or present smokers. The average BMI in the study population was 28, and in this study population, a positive MPI, myocardial perfusion imaging test, was detected in 7% of the patients. When we look at the diagnostic yield of the two tests, we see that the heart rate test was associated with a very high sensitivity for the detection of myocardial ischemia of 77%, as compared with only 19% associated with conventional exercise stress testing. Furthermore, the negative predictive value of the heart rate test was 98%, again suggesting that the heart rate test, if it is negative, can essentially rule out the presence of significant myocardial ischemia. Consistent with those findings, multivariate analysis showed that a positive heart rate test was associated with more than 8-fold increased likelihood for the presence of myocardial ischemia, as compared with only 2.7-fold associated with conventional exercise stress testing. And this resulted in a relative incremental value of more than 5-fold associated with the heart rate test as compared with conventional exercise stress testing for the detection of myocardial ischemia. So in conclusion, based on our pilot study and the current multi-center clinical trial, our data clearly indicate that the novel heart rate variability algorithm shows a high sensitivity and negative predictive value for the detection of myocardial ischemia in patients who do not have coronary artery disease, and that the sensitivity and relative predictive value of the heart rate tests is significantly higher compared with conventional exercise stress testing. And these findings suggest that the heart rate algorithm can be used as a simple screening modality for the early detection of coronary artery disease. Thank you.